Hello everyone and welcome to ESC 2025 here in Madrid. This is an episode of ESC Snacks and today we will be diving into some of the most exciting late-breaking clinical trials. I am Lenvent Pay from Turkey and it is my great pleasure to be moderating this session with two very special experts, Professor Carolyn Lam and Professor Metra. Welcome and thank you very much for being here. And first question, now we have several trials exploring new therapies in heart failure. So, from your perspective, how does these trials collectively shape the current and the future heart failure treatment?
You want me to start? Well, we had two major trials in patients with heart failure. The DAPA ACT-TIMI trial was done in patients with acute decompensation of heart failure, dapagliflozin versus placebo. The results were statistically non-significant, although the trial was underpowered for the number of events, very short follow-up time, 2 months, and a meta-analysis with the other trials with SGLT2 inhibitors in patients with acute heart failure showing positive results. So I think this trial is not going to change my clinical practice, and but confirms that these drugs are not acting mainly as diuretics and are safe in patients, also in patients with acute heart failure, and remain indicated.
Yeah, you know, Marco, I couldn't agree more. I think the trial was started 2021, where we still had questions about, is it safe or is it effective to start SGLT2 inhibitors in the hospital in a hospitalized patient? Frankly, I don't think it's even a question anymore, you know, and I think that explains why it had to be designed with a short follow-up, because if not, there's loss of equipoise to keep patients on placebo anymore. And the trends in the events were the right direction, but, you know, again, I do think it was underpowered, but the totality of the evidence is overwhelming that we should be starting these medications early and keeping it on in the absence of contraindications in our patients who are on it and then get hospitalized for heart failure. It's interesting that the next trial that was reported right on at our session was the other extreme of patients. It was the Victor trial, vericiguat versus placebo in compensated HFrEF. And so not the hospitalized, and in fact, half of that population was never even hospitalized before. And they were, you know, patients who were extremely well treated. I mean, I think the best of all the contemporary HFrEF trials, 60% on ARNI, 60% on SGLT2 already, and then randomized to vericiguat versus placebo. And it was to plug the evidence gap of Victoria, the prior trial that was a positive trial that really targeted the recently hospitalized or worsened patients. So Victor also did not meet its primary endpoint, but and that was a composite of heart failure hospitalization and cardiovascular death, but very interestingly showed as a key secondary endpoint that there was a significant reduction in CV mortality that was also shown in a reduction of all-cause mortality, sudden cardiac death, and you know, very basically consistent signal. In totality, and especially as we talked about, you know, pooled with Victoria, so you cover the entire spectrum of HFrEF, then of course it was all positive for the composite endpoint for mortality alone, for CV mortality. And I think altogether, we really have to consider if we now have another class of therapy that we should be considering in our patients with HFrEF that really is beneficial and could extend survival. What do you think?
Yeah. Yes, of course, for sure. I mean, we are still bound to the results on the primary endpoint, and we tend to think about this because we need simple things, but there was the result on cardiovascular mortality, and above all, the pooled analysis of the Victoria and Victor, I think it was convincing, showing a benefit both on the composite and the individual components on cardiovascular mortality and heart failure hospitalization.
If I may add, because I think John McMurray gave an excellent discussion of the why would hospitalization for heart failure not be reduced when cardiovascular mortality is reduced? And I think we are at a very interesting point in our heart failure trial practice and arena where hospitalization rates for heart failure are kind of going down. And we may be treating our patients more as outpatients.
And actually, they had
especially in the very well patients.
Actually, they had the analysis
exactly,
with the
when they added
outpatient administration of
the
diuretics, double events,
and then it
the
was positive.
significant P004. So yes, it's changing. We have patients who decompensate and don't go to the hospital, but are treated as outpatients. So that's.
Next trials, Odyssey HCM and Maple HCM trials. What are the key takeaways for clinicians?
Well, maybe I'll start.
Well, Odyssey was mavacamten in patients with hypertrophic cardiomyopathy, diastolic dysfunction, but no intraventricular gradient, and this made the difference. And the trial did not reach statistical significance also in this case. And I think there is the problem of the patient population which may be more heterogeneous, the problem of the dosing, which was not done on the basis of the reduction in the gradient, but just at the high dose. And so I would need further trials for sure in patients with non-obstructive hypertrophic cardiomyopathy to have an indication to myosin inhibitors. The other trial was more straightforward because was with the other myosin inhibitor, aficamten, in patients with obstructive hypertrophic cardiomyopathy versus beta blockers. And what did it show, Carolyn?
Oh, this was a very, I think this one is practice changing.
Yes.
So it was a beta blocker first or aficamten first trial, and it was very interestingly questioning this long-standing practice that we've had of always making sure that beta blockers are there. And basically, it was very positive in its endpoint that aficamten outperformed beta blockers in terms of the peak VO2 improvement. In fact, you see a decline with beta blockers. But what I found really interesting in the other endpoints was beta blockers didn't even reduce the LVOT gradient.
Yes.
I assumed,
Yes.
that it didn't even reduce the LVOT gradient, whereas of course aficamten reduced the
used
LVOT
to do
gradient.
some things like giving beta blockers to HCM patients without thinking about the evidence and the reason why to do this.
Yes, and I think that was a very, very good take-home message for all of us that in the presence of these advancements that we have, we should also question the long-standing practices and whether or not we can beat that and have a new first-line therapy.
New first line in the near future, do you think that?
Yeah, maybe, but I think a lot more
studies.
needs to be done to look into it. Where nobody is saying, and even in the discussion, that the presenter said, I'm not trying to say forget beta blockers forever and ever, because who knows about sudden cardiac death. But don't need to fail beta blocker to add aficamten or something. Like, we should be thinking of aficamten or cardiac myosin inhibitors in general first.
Thank you very much, Professor Lam, Professor Metra, for your sharing your valuable insights, and thank you all for watching.